Welcome to the webinar. My name is Shannon Zarilla. I am the Latina Share Gynecologic Cancer Program Manager. Hola, bienvenido al seminario web. Mi nombre es Shannon Zorrilla y soy la directora del programa de cáncer ginecológicos de Latina Share. Thank you so much for joining us all today. This webinar is being provided in Spanish and English. If you would like to listen to the webinar in Spanish, please click the globe button marked interpretation below at the bottom of your screen and select Spanish. You will be able to see the presenters, but listen to the webinar in Spanish. Ahora tenemos algunos recordatorios para usted. Este seminario web está disponible en español. Si desea escuchar el seminario web en español, haga clic en el botón del globo terráqueo en la parte inferior de la pantalla debajo y seleccione español. Podrá ver a los presentadores, pero escuchar el seminario web en español. This program is being put on in partnership between Memorial Sloan Kettering Cancer Center and SHARE. Before the program begins, I'd like to tell you a bit about MSK's Office of Equity and SHARE. MSK's Office of Equity was established to address disparities in cancer outcomes based on race, ethnicity, cultural differences, and socioeconomic status. The Office of Health Equity has three core areas of focus: patient access, research, and training. Learn more at mskcc.org. SHARE is a national nonprofit organization that supports, educates, and empowers anyone who has been diagnosed with breast or gynecologic cancers, and provides outreach to the general public about signs and symptoms. Because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information, please visit our website at sharecancersupport.org. All participants will be muted during the presentation. Once the speakers finish presenting, we'll begin the Q&A discussion. Please submit any questions through the Q&A section at the bottom of your screen. Remember that the speakers are unable to give medical information, so please keep your questions general. This webinar is being recorded and will be available on the MSK/Share website soon. Before we get started, we would like to learn a bit more about you all, our audience. Please take a moment to answer the 3 poll questions. Okay, so I see based on our poll, a lot of the people who are attending our program are patients. We have some caregivers and some healthcare professionals. Thank you all so much for participating in our polls. So now I'd like to hand it over to our first speaker, Dr. Liu. Dr. Liu, welcome, and please go ahead and introduce yourself.
Hi, everybody. It's an honor to be here. Thank you so much. My name is Ying Liu. I'm a GYN medical oncologist, which means I'm a doctor who treats women with gynecological cancers, and I specialize in giving therapies that go all throughout the body in pill form and IV form. And one of my interests is really helping women understand their risk for gynecological cancers and how best to treat them. So I am super excited to be here with everyone today. It is a very educated crowd. It sounded like everyone was really excited about genetic testing and everyone knew what a clinical trial was, which is wonderful. So I'm really happy to, share some information about ovarian cancer, as well as how we treat ovarian cancer and the importance of genetic testing, and talk about some of the areas of disparities and how we can work on this. And we have a great program today, and hopefully we'll have opportunities to interact. So let me just share, let me just share a few quick slides. I just have a few pictures that will hopefully help in our discussions. So I wanted to start with the basics and just ask the question of, well, what is ovarian cancer? Because not everyone is aware of what the ovaries are. We know that they're an important part of our gynecological or GYN system. And what I tell my patients is to think of an ovary like an egg. And I have a pink Easter egg here because that's my daughter's favorite color. And just like, regular eggs, our eggs are also an important part of the process of making children. And that is in general what the gynecological system is for. However, we can have cancers that arise in the system. And when you think about the ovary as an egg, the cancers actually come from the outside of the egg or the shell. And that's what we're kind of describing here. The stuff on the inside, the mushy stuff, it's actually very rare to have a cancer from there. So most of the cancers that we're talking about come from the outside. And it's a little confusing because when you look sometimes online or you look at research about ovarian cancer, you see that it's called not just ovarian cancer, but sometimes fallopian tube or peritoneal cancer. And I tell my patients that this is all the same thing because the lining of the ovaries, which is the egg, connects to the fallopian tubes, which is also present in your peritoneal cavity or your abdominal cavity. And the cancer can grow from any of those areas. So those are all the same things if you're hearing those different terms. The other thing I tell my patients is that there are different types of ovarian cancers based on what we see under the microscope. And the most common type is what we call a high-grade serous ovarian cancer. And you guys may have heard those words, but there are other types of ovarian cancer too that are a little bit more rare, and it kind of depends on what you see under the microscope. And that can determine their behavior. So some of them grow a little bit slower, and some of them are a little bit more aggressive, depending on the type and what we see under the microscope. And these are some pictures here that reflect that, and it's something we call histology. All right. So then what puts someone at risk for ovarian cancer? And how do we, change that risk? How do we look out for ovarian cancer? What are symptoms? These are all really important questions. So the number one thing that puts someone at increased risk for ovarian cancer is actually genetic. About 20 to 25% of patients with ovarian cancer have it because of a genetic reason. Now, what do I mean by that? I mean that they were born with something, a change in their DNA, which is the building blocks of life, really, that put them at risk for cancer, meaning that they had a higher chance of developing ovarian cancer. And this could happen at a younger age. And this is something that they were not only born with, but that was passed down to them from one of their parents. That's what we mean by genetic. And also because of that, they're at risk of passing it down to their children. So it can affect not just the patients, but their family members as well. And some of these gene changes you might have heard of, things like BRCA1, BRCA2. These are the most common genes that are changed, that are associated with ovarian cancer, but there's other ones as well. And that is by far the most common risk factor. Age is also a risk factor as we get older. And there are things that can decrease your risk. So actually having had pregnancies, breastfeeding, and using oral contraceptives contraceptive pills or birth control has been shown to decrease the risk. Now, unfortunately, we haven't gotten very good at preventing ovarian cancer, through testing, and that's partially because ovarian cancer is really tough to diagnose. The symptoms can be very, general. It could be things like feeling tired, having changes in your bowels, maybe feeling a little bit more bloating, maybe having some fluid builds up in your belly and not really knowing why, like gaining weight, things like that. And so many women, unfortunately, aren't diagnosed. They don't figure out that they have ovarian cancer until it's become much more advanced. And we really, unfortunately, haven't gotten good at screening for ovarian cancer, meaning using a blood test or an imaging test like an ultrasound, or something like that to try to find ovarian cancer at an earlier stage. For example, for breast cancer, we have things like mammograms that are very effective at detecting, breast cancer early when it's very treatable, very curable. And ovarian cancer, we're still working on that. And for women who are at increased genetic risk for ovarian cancer, there is a way to prevent ovarian cancer, but it's not through blood tests or ultrasounds or things like that. It's through surgery, and it has been shown that surgery to remove the ovaries, to remove the fallopian tubes, before the age at which the risk of ovarian cancer increases is effective to prevent ovarian cancer. And this here is a picture of what that type of surgery looks like. It's laparoscopic, meaning it can be done, with very little incisions, a small procedure, a quick recovery time. And this is kind of what the ovaries look like under the microscope. So, that is the gold standard for preventing ovarian cancer. But we are working and actively doing research on trying to find other ways, more non-invasive ways, through blood tests or other types of tests, to try to prevent ovarian cancer or detect it earlier. But right now, the gold standard is still surgery. Now, what happens if we diagnose ovarian cancer? So, most of the time women are diagnosed with ovarian cancer because they have these symptoms and it gets worse. And eventually there's a biopsy that shows ovarian cancer, or there's a CAT scan that's, suspicious for ovarian cancer that leads to a biopsy. And oftentimes the initial treatment is a combination of surgery and chemotherapy. And these are very, very important. In fact, I have pictures of our amazing surgeons here and some of our chemotherapy units. And this has sort of been the traditional treatment, is a combination of trying to get rid of as much of the tumor as possible through surgery, which can either happen before chemotherapy or kind of in between, in the middle of chemotherapy, what I like to call sandwich style. But the goal of both the surgery and the chemotherapy is to try to get rid of as much of the cancer as possible and put our women into what we call remission, a state where there's very minimal cancer or no cancer that we can see, and kind of try to keep them there. And I think, in the past, these therapies have been successful, but maybe not as successful as we would have liked, meaning that although we can get our women into our remission, with surgery and chemotherapy, oftentimes, unfortunately, after, months to years, the cancer could come back, and, women may need additional surgery or treatments. So the goal, recently has been, well, how can we improve upon our traditional, treatments like surgery and chemotherapy? Are there more targeted therapies that we can use? And I put this bullseye here to sort of show that there's been a lot of research in oncology looking at trying to target our treatments to the specific cancer type and the specific cancer genetics. What I tell my patients is, surgery is very good, but it takes out everything. Chemotherapy is also very good, but it's like when you're at war, it's a big bomb. It takes out everything. It's not selective. Whereas I tell my patients, targeted therapies, they're like the Navy SEALs. They're targeted. They're in for a mission. They're going for a specific, target, and they get in there, they do what they need, and they get the job done. So that's what we're looking for with targeted therapies. And I think the biggest targeted therapy that's been successful recently for ovarian cancer is something called a PARP inhibitor, which is a pill that is not chemotherapy, but actually targets specific changes in the DNA of the ovarian cancer tumors. Oftentimes, those BRCA mutations that I mentioned before, and it works to damage the DNA in just the tumor cells more selectively and helps to destroy the tumor cells and keep our women in remission for longer and hopefully get rid of the cancer. That's sort of the goal. Now, how does targeted therapy lead to disparities, and where are the disparities in ovarian cancer? So, you know, unfortunately, as we're developing these more advanced and targeted therapies, they rely on knowledge of genetics of the patient, genetics of the tumor to pick the right targeted therapy for the right patient for the right cancer. And where the disparities come into play is in who's getting genetic testing. Now, the good news is that the recommendation from multiple cancer organizations and most and almost all the doctors that you'll see is that every woman, everybody with ovarian cancer should have genetic testing of both themselves, meaning their own blood, and the tumor for the exact reason of trying to make sure that we have the right therapy, the right targeted therapy for them and for their family so that they know if there's something running in the family that's increasing the risk of ovarian and other cancers so that we can prevent cancers. So that's sort of the two reasons why genetic testing is so important in ovarian cancer. So, our bar is 100%. It should be 100%. And unfortunately, the studies have shown that we are very, short of that bar. A very disappointing study a couple of years ago showed that, in some states, it's only 34%, so less than half of women with ovarian cancer are getting the recommended genetic testing. Thankfully, when we looked at our MSK data and we've looked at some other data sets, it's a little bit higher. It's sort of in the 70, 80, even low 90% range, but it's not 100%, and there's a lot of variation. So I think we can do better. So what are some of the reasons, why people aren't getting genetic testing? Well, the studies have shown that, genetic testing, there's a lot of mistrust around genetic testing, because it's just a lot of, it's sometimes hard to understand why we're doing it, what the process is. People are nervous about their genetic information, being there. They're not sure what implications it might have. They're also worried about the cost. Is their insurance going to cover it? Which is all, these are all valid concerns. And so the studies have shown that there's disparities in who gets genetic testing based on their race, their education, their insurance. But actually, a good portion of it has to do with their physician too. Studies have shown some bias in who gets recommended genetic testing, and that if patients have their doctors refer it, they're much more likely to do it. And that we as physicians need to be better about recommending this for all of our patients, and not being biased for whatever reason. So I think these are all things that we could all work on, and we're doing a lot of studies to trying to figure out how to make the genetic testing process easier. I think we're all getting more savvy with technology, and so one of the hopes is that technology will help this process and bring empower patients and individuals to do their own testing. So there's a lot more direct to consumer or direct to patient testing. There's also more digital ways to do testing that makes it a little bit easier. Sometimes what I tell my patients is if we can all order food through apps and get that in, can't we all order our own genetic testing, send in, a spit sample and get the results? So there's got to be better ways to do that. And we're working on that. And we're also very interested in the patient perspective and all of your views on, well, what is it that, does this process make me nervous? What could be better? That's why I'm so glad we're having events like this today to talk more about ovarian cancer, the importance of genetic testing, and how to work on these disparities. So with that, I will stop and hand it back to the team.
Thank you, Dr. Liu. Now I'd like to hand it over to our second speaker, Livia. Livia, you can go ahead and introduce yourself.
Thank you. I'll start with a thought. Even though I walk through the valley of the shadow of death, I will fear no evil, for you are with me. Psalm 23, verse 4. Good afternoon. My name is Livia Gonzalez. On June 2022, after a total hysterectomy, I was diagnosed with stage 1 ovarian cancer. In my case, I only had a mass growing in my upper right abdominal area, stemming from my right ovary. I had no discharge, no headaches, no pain, no dizziness or fever. I had, as one of the symptoms that Dr. Liu mentioned, bloating, a lot of bloating. I went about my daily activities. I would go out, I would do grocery shopping, I would work out, everything was fine. I had no history of gynecological cancer in my family, on my father's side or on my mother's side. However, the mass continued growing and I had a CT scan. I must emphasize the importance to a woman to listen to your body. You must voice your concerns to your physicians, GYN obstetrician. It is crucial. If it weren't for this, I could have missed my diagnosis. As I was explained, that ovarian cancer often is silent and more difficult to diagnose without a biopsy or in early stages. I don't have the words to express my appreciation that I had a wonderful medical team of my GYN, oncologists, nurses, social workers, to name a few, that brought up to me the importance of the genetic testing to see if I had a genetic mutation. I was explained the importance as this pertaining to my future and my grown children. Had I come positive for the BRCA gene, that meant that my children would have 50% of being positive also for that gene. The genetic counselor, I remember her name is Deborah. She was so thorough explaining the genetic testing and even explaining the bad part of it, that if I would have been positive for BRCA, down the line, I would have probably developed other cancers, including breast cancer, colon cancer. And she brought it in such a clinical, but at the same time, in such a empathetic way. And I thought to myself, let me not overreact. Let me wait before I cross the bridge. So that waiting time of, I believe, 3 months was like so anxiety provoking. But finally, my results came back, and thanks God, I was negative for the BRCA. My genetic testing was good. And she explained the results very thoroughly. I got also a written report. I am blessed to have the wonderful medical team that I have addressing my medical management and care needs. And I include friends, people from my congregation, resources, especially Share Latina, that has been wonderful with me, woman to woman. And of course, my adorable children, Jose, my beloved first son, my daughter, Veronica, who today is a paramedic. They were with me during the whole process, going to the doctor's appointments, during the surgeries, and during the challenging process of the chemotherapy. Again, all these supportive systems have been crucial, but most of all, my faith has kept me going and pushing forward, always forward. Um, Again, I love my cancer survivors, my patients from Share, the woman, my warriors that are there fighting. And again, the best and the most important advice, have genetic testing. It is crucial. It is important. It saves lives. Thank you.
Thank you so much, Lydia. Now we're going to move on to our next section. It's the Q&A. So you can still submit questions in the Q&A section at the bottom of your screen. We will get through all of the submitted questions, but we may not be able to due to time constraints. And also, finally, remember that the speaker cannot give personal medical advice, so please try to keep your questions general. So our first question for Dr. Liu is, how do you test for ovarian cancer?
It's a good question. It's a good question. And Lydia, thank you so much for sharing your story. And unfortunately, your story, just like you said, is so common because, like you said, ovarian cancer is often the silent cancer. Um, this is what I tell my women. I tell them women are amazing. Women's bodies are amazing. You know, we carry children. We often, you know, your body stretches so much. Your pelvis is able to accommodate that. And that's the blessing. But the flip side is sometimes cancer can grow in that amazing body without you knowing it, just because we as women go through so much. We're used to doing so much. We're used to pain. We're used to bloating. We blame it on being tired or not eating right or, you know, all those things. I feel like all the women who come and see me, they're so busy, you know, just like Lydia, they're mothers, they're working, they have things going on. These aches and pains, they just they keep going. They're warriors, just like Lydia said. So often it is very hard to diagnose ovarian cancer. And part of that is because there is no good screening yet. You know, we all know we go for our yearly mammograms, you know, we see our doctor, we do our pap smears. These are ways to detect other cancers, but we don't have that for ovarian cancer, which is why, you know, webinars like this are very important to just educate people about what is ovarian cancer, what are the symptoms, why is the genetic testing important? Because for a lot of women, knowing that they're at inherited risk or genetic risk is a way to say, well, I need to be extra aware. Maybe I need to do extra things like the prevention surgery to not only prevent the ovarian cancer, but just to make sure everything is okay. Unfortunately, most women are diagnosed when their symptoms get just too much. And every, you know, sometimes that's when the swelling in the belly gets too much, or there's pain, or there's something that leads you to go to the emergency room. Just like in Lydia's story, it usually leads to some kind of imaging, whether it's a CAT scan or something that finds something abnormal, which usually leads to a biopsy or a surgery that then gives the confirmation of the ovarian cancer. And that is in general how ovarian cancer is diagnosed. My vision and a lot of people's vision is that one day we will have a screening test, we'll have a blood test or something that'll say, oh, there's something atypical here. It's not ovarian cancer yet, but it's early. So, let's keep an eye on it. Let's do something. Let's do an intervention to prevent it. That would be the goal, but we're not there yet. Right now, the best way to prevent ovarian cancer is to, be aware of it, be educated, just like we all are, and then do the genetic testing, just like Lydia said. And if you are at increased risk, do the recommended surgery to reduce that risk, or enroll in one of our clinical trials where we're trying to look at other ways outside of the surgery, to prevent ovarian cancer. So that's kind of where we are right now.
Thank you so much, Dr. Liu. We have another question here that says, what are the risk factors for this type of cancer?
Absolutely, that's a great question. I think, like I said before, genetics is the number one risk factor, but also our best opportunity for prevention. I try to limit the amount of numbers I throw at people, but I do find this kind of compelling. So ovarian cancer as a whole is rare. Breast cancer is much, much more common. The average woman's lifetime risk of something like breast cancer, out from 0 to 100% is 12%. Comparatively, the average woman's lifetime risk of ovarian cancer is much less. It's 1 to 2%. So 10 times lower. But if you're somebody with a BRCA mutation, like a BRCA1 mutation, so a genetic risk, that 1 to 2% goes up to 40 to 45%, which is much, much, much higher. That is the major risk factor. The other smaller risk factors are things like age, being postmenopausal, which is related to age. But by far, the biggest factor is genetics.
Thank you, Dr. Liu. And then we also have some live questions. One of our live questions is, what types of genetic mutations do PARP inhibitors treat?
That's a great question. So PARP inhibitors work by blocking one of the pathways that fixes DNA. And the way cancer develops is because your normal cell, normal parts of your body, all of a sudden develop a change in their DNA. And oftentimes this happens because they can't repair the DNA. So the reason BRCA mutations lead to this increased risk of cancer is because BRCA is a very important protein or important part of the DNA repair machinery. And so when you have a change in that and you're born with that, from birth, your DNA doesn't repair as well. And so then you're more at risk for developing cancer. Now, ovarian cancers in general have a lot of issues repairing their DNA. So probably the question you're thinking is, well, if the PARP inhibitors make that worse, how does that lead to killing the cell? Well, what happens is, the ovarian cancers in general, and especially those with BRCA mutations, can't repair their DNA. So the mutations are accumulating. And then you throw in the PARP inhibitor, and it also makes it harder to repair DNA because there's different ways that your cell repairs DNA. And BRCA takes care of one part and PARP takes care of the other part. So when you have both of them, the mistakes just build up, and all of a sudden you reach a critical point where the cell says, I can't take it anymore. There's too many mistakes, and it just shuts down. And that's in essence how the PARP inhibitor works in mutations like BRCA mutations. It in scientific terms, we call it synthetic lethality, which is a fancy way of saying the two things work together to make it even more toxic to the cell. And so it works very well with cancers related to BRCA and also genes related to BRCA. A lot of these are in what we call the homologous recombination, or HR pathway. And some of these genes you may have heard of. They're very new, like BRIP1, RAD51, BCD, PALB2. I tell my patients it's alphabet soup, but it's sort of all in that HR pathway. And you may have come across things in your reading that about HR deficient and HR proficient ovarian cancers. That is a distinction that helps us determine how well we think a PARP inhibitor would work, where the HR deficient, meaning the cancer cells are not good at repairing DNA through HR, probably the PARP inhibitors are more effective in that group of ovarian cancer. I hope that makes sense.
Thank you so much, Dr. Liu. So when it comes to genetic testing and ovarian cancer, who should consider genetic testing, and what is somatic testing?
Great questions. Great questions. The answer to this one is easy. Everybody. Everybody with ovarian cancer should consider genetic testing. I'm going to expand that even further. Sometimes you find out about a relative who had ovarian cancer decades ago. They may live in another country. They may have died. You need genetic testing, right? They weren't able to. So then you would qualify for genetic testing. So I always tell people, everyone with ovarian cancer, and if they're not able to, their next relative, whoever we're able to get, anyone with a family history of ovarian cancer should think, do I need genetic testing? And the answer to that is probably yes. And what's somatic testing? That's a great question. These are fancy words. This is a very educated group. We could tell that from the questions at the beginning. I'm so happy. It means that people are listening to their doctors. So somatic is a fancy way of saying tumor testing. When I say genetic testing, you're right in that that's a broad category, and I'm not being specific enough. There are different types of genetic testing. There is genetic testing of the tumor, which we call somatic. So that genetic testing just tells us what's different in the tumor. There's genetic testing of what we call the germline, which is your natural cells, the ones that are passed on to you. And I tell my patients, we do both. For ovarian cancer, you're supposed to have both, and you're supposed to find things in the tumor, and you may not find things in the germline, because the tumor is not normal. We know that because it's cancer. We know it's going to have mutations, but which ones it has is really important in helping us find the therapies. In the germline, the majority of people will test negative, just like Lydia did. And that's great. And that's also important to know, because like Lydia said, if she tested negative, then her children are not at risk of getting a BRCA mutation or something else from her because she tested negative. So that's, even a negative test result is really important for you and the family. And so that's the difference between the two types of genetic testing. But in ovarian cancer, it's easy. You need both, and everyone needs it.
Thank you, Dr. Liu. And then I'd like to talk a little bit about clinical trials. So the audience wants to know what is important to know about clinical trials. And then Livia, I wanted to ask, did you know about clinical trials when you were diagnosed? And
Okay.
did your doctor talk about clinical trials to you?
Okay. I go, okay. Well, in my situation, as Dr. Liu mentioned, they gave me the diagnosis during the surgery. She found the cancer, stage 1. After that, I went back to the doctor. We went over the treatment, the chemo, and all of that. But a trial treatment was not mentioned. What was really emphasized was the genetic testing and the chemotherapy.
Thank you, Lydia, for sharing your experience. Yeah, clinical trials are important to be aware of, just to know that they exist. It may not be right for everyone and at every time. And there's different types of clinical trials. What I tell my ladies is, I always keep an eye out for clinical trials for them if I think it's in their best interest, depending on what we're looking for studying. And it also depends on, where you are in the cancer journey, right? In Lydia's situation, where you were diagnosed, thankfully very early and are doing so well. We have clinical trials that come and go sometimes to help women. For example, I know you said the chemotherapy was really tough, and we recognize that, and we're starting to develop more clinical trials to support women through chemotherapy, to help do things like rehab, physical therapy in the home with telemedicine. A lot of our surgeons are looking at ways to reduce stress around surgery because, of course, that's another stressful event. They're utilizing things like music therapy in the hospital and other things like that. So those are types of clinical trials that maybe people don't think of when they traditionally think about clinical trials. So I always encourage my ladies to keep an open mind because sometimes clinical trials are different from what you expect. I think most people may think of a clinical trial as this as like an investigational drug that was tested in mice, and this is the first time you're going to test it in a human and you want to test it on me. I think that's some of the bias, and I tell my patients that that's not every trial, certainly because certainly at Memorial Sloan Kettering, because we do a lot of basic science research, we do have trials like that where the drugs are very new. We're still learning about them. And I'm very upfront with people when I say, we don't know a lot. This has only been tested in mice and cells. Is this something you want to consider? And part of the process is us having a conversation about, well, what are the risks? What do we know? Is this the right thing for you? Is this the right time? But I also tell my patients there are other trials in what we call different phases. So that there's usually 3 phases to a clinical trial. What I just described is sort of our earliest phase 1 trials, where we're still trying to figure out a lot about the drug, and maybe it's just being tested in people. But some trials are in more advanced phases like more advanced phase 1 or 2 or even 3. And these are with drugs that we've tested for a long time or are already approved and being used in other cancer types that have known safety, and we know how to use them. We're just using them in a different way. And so I tell my patients, this is different. This is a very good medicine. This is something I wish I could give you, but I can't because of laws and regulation, except on this clinical trial. And so the balances are on a clinical trial. Generally, the benefit is that you have access to a medicine that's not otherwise available, that your doctor couldn't otherwise prescribe you, that may work better for your cancer than what's currently available. That would be the hope. That's the hope behind all of the trials we design, that what we're testing is better than what's currently available. And so trials give you that opportunity. But I'm also very upfront with my patients about the risks of clinical trials. The main ones being we don't know if the drug is working. That's why we have to test it. And that the main thing is safety. There may be new things we learn, and you would be part of that process. And so the main focus of a clinical trial, I always tell my ladies, it's not the drug, it's not just the drug work, it's you and your safety. Everything we do is for patient safety. So clinical trials, I tell people are just, they take more time because more people have to review everything. More people have to see you. We have to, make sure we know all the side effects you're having. We ask you a gazillion questions. We ask you to do additional tests just to verify the safety. So those are kind of the downsides. But the benefit is that every single one of our FDA approved drugs, like the olaparib, the PARP inhibitors, were at one point in clinical trials to show that they worked. And those women, those patients who were on the clinical trials, they had access to those drugs often years before everyone else did, just because this process takes so long. So that's the trade-off of clinical trials.
Thank you, Dr. Lynn. We actually have a live question that says, how can I participate in clinical trials associated with GYN cancers as a woman?
That's a great question. So our MSK website has a lot of the clinical trials that are listed. Clinicaltrials.gov is a national registry of all clinical trials. And so those are definitely ways to get access to clinical trials. Unfortunately, the nature of the clinical trials is they sometimes come and go. They sometimes are only open for a period of time. So those lists are being continually updated, but those are really good resources to turn to look for clinical trials.
Thank you so much, Dr. Liu. Yeah, and we'll make sure to put all the resources at the end of the presentation. I also have some more questions. Lydia, feel free to also answer these questions as well as Dr. Liu. So we have some questions regarding self-advocacy. So when you do get a second opinion from another doctor, how do you tell your patients to go about this? And how do you feel, Lydia? How can you best advocate for yourself with a healthcare team?
Who goes first, Dr. Lu or myself?
Lydia, you go first. You go first.
Okay, thank you. Yeah, self-advocate, that's very important. And I think the initial step is that awareness of your body and being proactive. And if I'm not English proficient, I have the right to ask for a translator. I have the right also to receive copies of my medical documentation. I have the right to ask questions. I always during my process, my daughter, she works in the health system, she would accompany me because again, I was in the initial stage of the cancer diagnosis, the chemos. I was like in a denial. I was not completely tuned with my medical condition. So it's always good to have someone accompany you, probably a family member, a best friend. Also ask, usually the hospitals, they have an excellent unit of oncologists, of social work that are specialized in oncology, and they can connect you with resources. With, for example, I had help for transportation, they will pay my taxi. They were very accommodating. But your best advocate is yourself, and it's okay to ask for help. Don't feel ashamed, don't feel embarrassed, don't feel weak. It's okay. It's a process.
Absolutely, Lydia. That is so important for people to hear. And thank you for saying that. You're absolutely right. You are your own best advocate, but it never hurts to have a village. I absolutely love it when I walk into a patient room and there's a whole room of people there to support the patients because it is hard. It's so much to remember. It's so many feelings, so much information. And it's good to have people there to help listen, so that you guys can, make sure someone is hearing, all of it because it's hard to remember it all. And then you're absolutely right. There's a lot of resources that institutions have, like patient navigators, support for things like parking, and then support groups and organizations like Share, which are so important. And then, I think part of advocating for yourself is getting as much knowledge as possible. I know we've harped on how genetic testing is one way to do that, but you're right. Second opinions are another way. And I always tell my ladies that I am a fan of that. I think knowledge is power, getting other opinions, getting other options, getting opportunities for other clinical trials, other programs. These are all good things. And if that's something that you want, you should definitely think about doing that. And I think medical providers should support that and usually do. Absolutely.
Thank you, Dr. Lu and Lydia. So well said. Um, there are a couple more questions here. So these are regarding treatment. So the first is, how can we understand all of your treatment options for ovarian cancer? And then Dr. Lu, what determines who is a good candidate to receive bevacizumab for ovarian cancer?
Yeah. These are great questions, and they're tough, because there's sort of nuances to help us determine the best treatments. Bevacizumab is a very common treatment, and it's a good treatment for ovarian cancer. So I can take a step back, and I can sort of share my approach, and what I do with my patients. So I think my job as the healthcare expert is to try to use my experience, my medical knowledge to sift through the options and pick the ones that I think are in my patient's best interest, and then talk to them in a way that they can understand to help to choose together, and make my opinions known, but also take into account their feelings, because in reality, like Lydia said, patients are so educated, they're so invested, their family members are too, they advocate for themselves, but but sometimes they say to me, how do I know which one is the best trial? How do I know which treatment is the best one? It's almost overwhelming. And so I say, we're a team. My job as the medical person is to kind of filter the medical content, but there are some times where it's very clear that this treatment is the right treatment. There are other times when we have options. And when we have options, for example, if one of the options we're talking about is a chemotherapy and we're trying to decide if we want to add bevacizumab, which sounds like might be what this person is asking, we talk about the risks and benefits, right? So we talk about things like, well, adding bevacizumab has been shown to make chemotherapy work better and keep women's cancer under control for longer. So from that standpoint, it is beneficial. But bevacizumab, has side effects, and if you have certain medical conditions, it may not be in your best interest. Some of the side effects it causes may also not be in your best interest, and it requires monitoring and things like that. And so those are kind of the discussions that we'll have to figure out the best treatments. Same with clinical trials. It's oftentimes the clinical trials come with 30 pages of information and a lot of science about the background, and I think my patients rely a lot on me to pick the ones that I think are the right fit. So I'll tell them, I looked through all of them and this is the one that I think is the best fit, and I'll say why. It might be something like, your genetic testing showed this change, and that change is exactly what is being targeted by this clinical trial. So that's why I think this is a really good match for us. So that's kind of how I approach these decisions.
Thank you, Dr. Liu. We also have some live questions that came in. Someone asked, would you recommend a PARP inhibitor to someone who does not have a genetic mutation?
That's a good question, and it's also complicated and kind of depends on the specific situation, because you're absolutely right in that PARP inhibitors could be used to treat ovarian cancer even without BRCA mutations. We do often do something called testing for that HR deficiency that I talked about earlier, and in tumors that are HR deficient, even without BRCA mutations, there may still be additional benefit. But oftentimes, it's weighing the risks and benefits. What's the potential benefit of the PARP inhibitor? What are the risks, right? Because the PARP inhibitors have side effects too. They can, make you feel tired, give you joint pains, have GI symptoms, and then in the long run, there may be a small risk, increased risk of a second blood cancer. So, sometimes I say this to my patients: if taking medicines was as easy as eating ice cream, we just give everybody the medicines, right? We'd all be eating the ice cream, but it's not. There's side effects we have to balance, and so part of our job is to educate people about the risks and the benefits, and then make that decision together.
Totally. I agree. Thank you so much again, Dr. Liu. We're gonna move into the closing questions. So, Dr. Liu, what would you say are the main takeaways you would like to give to patients? And then Lydia, feel free to chime in after Dr. Liu. Do you have any takeaways from your experience that you can share with the audience?
Absolutely. So I think my parting words would be that, knowledge is power, and knowledge helps you overcome fear. And I think the genetic testing is an important part of that. only with the genetic testing will we have the power to find, the right treatments and also help you and your family prevent cancer. So I would say, acknowledge the fear, but embrace the knowledge that helps you overcome that.
And then Lydia, what would you say would be your key takeaways from your experience that you can give to the
Yes,
audience?
yes, so many things, so many things. Absolutely, knowledge is crucial. Testing, genetic testing, crucial. But looking back at the journey that I have and the challenges that I have in the future, cancer has taught me, not that I want it back, has taught me so many things, has taught me, there has been like a shift in my personality. Like now I pay more attention to details, to the here, to the now, to this positive exchange of knowledge, of information. I used to be, prior cancer, it was always the future, me in control, doing this, doing that. This has given me another outlook of life and has taught me what really matters. The here and the now, taking care of yourself, using these wonderful resources, and and continue pressing forward, continue using your resources, your faith, whatever faith, it's really important, and that there is a solution, and that there technology is beautiful and we have the resources. Let's utilize them, and let's listen to our body.
Well said. Thank you so much, Lydia, for letting us know your take, and Dr. Liu, thank you as well. So for our audience, we actually have 2 final poll questions to wrap up our webinar that will show up on your screen. So if you could please feel free to answer these. Give you a minute to look these over. Thank you all so much for answering our poll questions. So it looks like a lot of people would proceed with the first question. If your doctor recommended genetic testing, they would feel comfortable proceeding with this. And then in our second question, we actually got 100%. People now know or are educated on what is a clinical trial, which is really wonderful. So please, if you could continue spreading this education, as Dr. Liu and Livia said, it would be wonderful to continue this advocacy work and everything that we encourage you all to do. Thank you so much, Lilia and Dr. Liu, for such an informative program, and thanks to all of you for participating and submitting your questions. So please know the slides and recording of this webinar will be available on our website, sharecancersupport.org, in about 1 to 2 weeks, and they will also be emailed to all of you guys who registered. We also encourage everyone to check out our resources for ovarian cancer patients. We just put into the chat our available support groups in English and Spanish for ovarian patients. And within our follow-up email with the recording, we will also make sure to include MSK's resources, Latina Shares resources, and Share Cancer Support's ovarian-specific resources. So if you could please take a moment to fill out the survey at the end of the webinar. The survey will show up in your browser once the webinar ends. We would really appreciate you to take the time to do this for us. And lastly, all surveys are anonymous and confidential. So I just wanted to say thank you all again and conclude the webinar. Thank you all for attending. Thank you so much, Lilia, for sharing your story. And Dr. Liu, it's always a pleasure. We are so glad to have you on board. And thank you all again for attending. Hope everyone has a good night.
Good night. Thank
Good
you for
night, everyone. Thank
Bye,
you.
everyone. Thank you.